Thank you everybody for joining us this morning as we join together for our second educational module as a part of the Improving the Quality of Care for Prevention and Treatment of Childhood Obesity MOP project through ICAP. Dr. Rao is going to be our presenter today. Dr. Rao is the Vice Chair of Departments of Family Medicine for the North Shore University Health System and the University of Chicago. He is also the Clinical Associate Professor at the University of Chicago. Dr. Rao is the Vice Chair of the American Heart Association's Obesity Committee and has served on the American Medical Association's Expert Committee on Child and Adolescent Obesity and was also a member of the National Quality Forum's Child Health Steering Committee. Dr. Rao is the former Clinical Director of the Weight Management and Wellness Center at Children's Hospital of Pittsburgh and former Associate Professor of Pediatrics at the University of Pittsburgh School of Medicine, where he also served as the Assistant Dean for Faculty Development. Dr. Rao has taught clinical epidemiology and biostatistics to medical students for more than 10 years, and he is the author of more than 50 publications, including 3 books. Dr. Rao is a graduate of McGill University School of Medicine and completed his residency and fellowship training at the University of Toronto and the University of Pittsburgh. So we are grateful to have him join us today and present on the hypertension for adolescents. So with that, Dr. Rao, I will turn it over to you.
Okay. Thank you, Sarah, and thanks to everyone who was able to join us this morning. I know how busy we all are. So this is a very basic module, and I think the reason that it's basic is because we have not come a long way in terms of screening, evaluation, and management of high blood pressure in children. It's still something that's kind of unfamiliar to many people, so we're going to go through a lot of very basic things this morning. So let's see if I can. So the project's funded by a grant, as you guys know, from SPRAG, the Memorial Institute, and from IDHS, the Family Health Services from Illinois Department of Healthcare for the overall projects. I don't have any financial relationships to discuss or to disclose. Let's begin our journey with looking at the origins of heart disease. And of course, it was discovered some time ago through autopsy studies. So through unfortunate circumstances, very young children sometimes die. And autopsy studies did reveal, going back 30 years or so, that many of these very young children have the beginnings of atherosclerotic disease, even as early as age 5. So you start to see foam cells, which you see here on the left of the diagram, progressing to fatty streaks, to intermediate lesions and atheromas, and eventually through plaques, which begin to form from the 4th decade of life onwards. So essentially, this I think is really important because it lays the foundation for the concepts. The heart disease begins very, very early in life, and also that the risk factors for heart disease later in life actually have their origins very early on in childhood, including high blood pressure, which is the focus of our discussion today. So we know that screening for hypertension is recommended. Unfortunately, it is very infrequently recognized. So from the Cleveland Clinic, which is a fairly advanced healthcare system with widespread implementation of electronic health records, Hansen, Gunn, and Kilber, this is going back to about 2007, found only that about 26% of pre-hypertension, so that's blood pressure that's elevated but not elevated to the point of hypertension, and hypertension was being recognized in children when they did a detailed chart audit. I actually did a study in Pennsylvania that looked at primary care pediatrics practices, and then I found almost exactly the same thing, that the vast majority of cases of high blood pressure were not recognized prior to a practice-based intervention. We did do an academic detailing and a chronic care model intervention that improved rates of recognition, but still very, very suboptimal. I think one of the disappointing things about that particular study is that in some cases the blood pressure was extremely high. And not only was there no recognition, but there was hardly any documentation in the chart apart from the elevated blood pressure. There's no recommendation for follow-up, no sign whatsoever that this was being recognized or managed appropriately. And that was in 2009. So it's unlikely that things have really improved that much. So why does it matter? Well, roughly 5% of children have high blood pressure, and we know that the majority of that is completely unrecognized. So if we did a recent audit at North Shore, for example, that shows that roughly about 0.9 to 1.1% of children have been diagnosed with high blood pressure, which means we're probably, assuming that the population isn't too different than elsewhere, missing 70 or 80% of it. We also know that blood pressure is steadily increasing across the pediatric population. And this, of course, is at least partly due to rising rates of obesity. We know that pre-hypertension, so these are elevated blood pressure readings that don't qualify as hypertension, that has a tendency to progress to hypertension at a rate of 7% per year. So among 100 pre-hypertensives, roughly 7 will progress to full-blown hypertension. We know that hypertension is persistent in about a third of boys and in a fourth of girls. So, and this, of course, varies significantly depending upon age. If you have hypertension as an adolescent, you're much more likely to have hypertension as an adult. But overall, across the entire population of children, we know that childhood hypertension has a tendency to persist into adulthood. So it matters for some basic reasons. First of all, blood pressure screening is an important part of the new integrated cardiovascular risk reduction guidelines that the NHLBI put out approximately a year and a half ago. I was actually a member of the steering committee, and I was the steward for the hypertension measure in children. So screening for hypertension is a national quality forum endorsed quality measure. As we move towards more quality-oriented care with the patient-centered medical home model, accountable care organizations, and other mechanisms that are being put forth by the government, the quality forums and measures are more likely to be widely adopted and used for payment and reporting. So therefore, I think that we will all be compelled to really take this problem much more seriously. It matters as well because we do have effective treatments, which we'll discuss later on in the presentation. So we have to ask ourselves this question: are we comfortable with missing hypertension in children? And if I could just share an anecdote with you. My own daughter's pediatrician, for example, told me that he quite honestly didn't like taking blood pressure because he wasn't really sure what to do with an elevated reading. And to get parents to follow up and to go through treatment was a process that was characterized by a lot of uncertainty in terms of exactly what to do. So I think this is a prime target for quality improvement in education, which is why we have this module, because there is such a big gap between what we know and how we practice. It's an ideal opportunity to make a significant improvement. So why do we miss high blood pressure? Well, first of all, in some cases, blood pressure simply is not taken. And that's quite common. Most of the participants in the MOC program and in the practices that are involved, based on our baseline data, are actually checking blood pressure quite often. But that's not true across the board, across the entire population of primary care pediatrics. We often miss high blood pressure due to improper technique. As we all know, the younger the child, the more difficult it is to get a meaningful blood pressure reading, and it does take some time and some practice. We miss hypertension because of the complexity of interpretation of blood pressure in children. So it's not as straightforward as in adults, where we have one fixed number above or below which defines appropriate or inappropriate levels, or ideal, optimal, etc. levels of blood pressure. It's more complicated and requires knowledge of a child's age, of course, and their height percentile and their sex. And of course, there's a lack of knowledge of follow-up and treatment guidelines. So the age-old question: well, yes, I can screen for high blood pressure, I can take a blood pressure, I can even calculate the blood pressure percentile. But then what do I do once I have that particular information? I mean, do they follow up? Do I put them on medications? What are the basic guidelines, and are those guidelines implementable, and are they effective in reducing the scope of the problem? So let's start with the basic measurements and when these should be taken. So no measurement of blood pressure is recommended between birth and 3 years. So there's no routine measurement. Now, you can measure under special circumstances, and I haven't listed all of these. So these are often children with specific chronic illnesses, such as chronic kidney disease, or a very strong family history suggestive of high blood pressure at a young age, for example. But these are rare circumstances in which we would have to take high blood pressure in these kids. We really begin routine measurement at age 3, and routine annual measurement is what's recommended. So this would be in combination with annual well-child checks, for example. And what's recommended is just taking the blood pressure once a year. And beginning at age 18 and thereafter, blood pressure measurement is recommended at all visits, as it is in adults. So how have we performed with respect to it? First of all, the information I presented to you initially may have seemed a little bit bleak. And this chart, I think, is another sort of health services research chart that uses the National Ambulatory Medical Care Survey that shows that performance has kind of improved and somewhat plateaued or decreased recently. So in terms of how often blood pressure is taken at all visits, there is a modest improvement with a slight plateau. In terms of preventive visits, again, improvement between 2000 and about 2008, but slight decrease here. And if you have a situation in which the child is overweight or obese, the child is more likely to have a blood pressure measurement taken, which is entirely appropriate. These decreases may not be significant because the National Ambulatory Medical Care Survey is only done as a sample annually. It may be an aberration. So we may actually be improving as well. In terms of a technique, I strongly recommend the NHLBI's Pocket Guide, which gives you a description. You can find this on the NHLBI's website in conjunction with the Cardiovascular Risk Reduction Guidelines. So the correct cuff size is important. It depends upon the arm size. It is basically the largest cuff that will fit on the upper arm with enough room for the stethoscope head. We all have in our offices, most of us have appropriate sized cuffs. But as you get into adolescence and especially with heavier children, it's important to have a full range of cuffs, not just an adult cuff, but even a thigh cuff in some cases would be appropriate for children who are very obese. Blood pressure should be measured in the right arm of a relaxed seated child. Of course, easier said than done. Auscultation is still the gold standard. Now, the automated blood pressure machines can be used, and there's also a machine called the BP True, which takes 6 measurements over 5 minutes and gives you a very accurate reading. The problem with the BP True, even though it has been recommended for children, is getting a child to sit still for that long. It is a real challenge, of course, and it, of course, can be disruptive to flow. So some of these machines, I think, can be used to confirm previous elevated readings, but in terms of screening itself, I think the basics of simply taking the blood pressure, either yourself or, of course, with an MA or a nurse, is the most appropriate way to do it. So we have other mechanisms available, including remote devices, etc., but these are still not very widely used. Generally speaking, if you have an automated blood pressure cuff, you should retake the blood pressure by auscultation. So here's another diagram basically in terms of technique. You'll see basically you want to have it around the upper part of the arm. The bladder length is about 80 to 100% of the arm circumference, and the width is about 40% of the arm circumference. So this is a standard pediatric cuff, which most of us have, which should be used. Now, once we've taken the blood pressure, of course, we are left with the challenge of interpretation. So the standards for high blood pressure are based upon, let me see if I can slide this out of the way, are based upon age, sex, and height. And this has lent itself to a great deal of complexity. And these have been published through the NIH and, of course, in pediatrics since that time. But it does make interpretation complex, and the tables are extremely cumbersome to use. So in the academic detailing study that I described to you that we did in Pennsylvania, for example, we actually had color-coded charts in each room that the MAs and nurses could use to see if a blood pressure was in the approximately the, was it normal, was it elevated, was it stage 1 or stage 2 with different colors. And even that was considered to be quite cumbersome. I think what happens in many cases, including with physicians, is that if you are involved in taking blood pressure quite often, you start to make assumptions as to what's elevated and what isn't. And the problem is that you often miss a lot of borderline cases, and especially in young children where a blood pressure of 110/80 may not sound terribly high, but in a young child with a very low height percentile, that may be quite high as well. So interpretation is complex, and the tables themselves are extremely cumbersome to use if you've ever tried to use it. So here are some alternatives that I was able to gather. I think we did do a survey of the MOC participants initially. The majority are using electronic health records, of course, which make it much easier. So the system I use is Epic, and this is a smart set within Epic. You can get, this is actually something that gives you interpretation, etc. So this is from a specific practice. I don't have access to this particular smart set, for example, but within Epic itself, there are other ways to identify whether blood pressure is high or not. There's the dot phrase called .bpfal, so it's .bpf as in Frank, AL, which will give you the blood pressure percentiles, and the thresholds that define hypertension. So if you ever are in the progress notes section and you put in your vital signs, if you just type in that particular dot phrase, you'll get all of that information quite easily. This is HealthWatch Pro, and HealthWatch Pro I recommend to anybody that does not have an electronic health record system. HealthWatch Pro is available for approximately $50 for your practice, so it's extremely inexpensive. And prior to having electronic health records, when I was the director of the Pediatric Obesity Center and we needed a large number of reports on every single patient, we used HealthWatch Pro a lot. Essentially, it gives you the height, weight, BMI percentile with specific interpretations. It also gives you lipid percentiles. It also, as you can see, will give you a blood pressure and blood pressure percentile. So here it's a little bit difficult to see, but it'll give you diastolic blood pressure percentile 50 to 90, which just basically means it's in the normal range. When it exceeds the normal range, it will give you a more specific percentile. So this is extremely valuable information. It gives you a growth chart. It gives you a patient report that you can actually give to the patient. So for those of you who don't have electronic health records, this is certainly the system that I would recommend. It's a freestanding program that can be installed on any computer. So let's say now we've moved to our next step. Essentially, we have interpreted our blood pressure correctly. And the question comes up, well, what do we do? And this is a tough thing for us to do because sometimes the diagnosis of elevated blood pressure can be quite alarming to a parent and family. And so to kind of put in place a follow-up mechanism can be challenging. It's again, this is all relatively new in terms of the seriousness with which we're taking blood pressure. So incorporating systems within your practice to manage the problem is extremely important. So if the blood pressure is normal, let's say we have a child who's between that age of 3 and 17, and we've just checked it once. So the systolic and diastolic blood pressures are both below the 90th percentile. We would simply recheck in a year. If they are pre-hypertensive, in other words, we have blood pressure between the 90th and 95th percentile, or it's over 120/80, and it's less than the 95th percentile, the correct process is to recheck in approximately 6 months and to begin weight management as appropriate. One of the important things to note is that it's either of these two blood pressure. So if the systolic, let's say, is above the 90th percentile, but the diastolic is normal, they still qualify as prehypertensive, and that applies to stage 1 and stage 2 hypertension as well. If they are at the stage 1 hypertensive level, so that's a systolic or diastolic blood pressure at or above the 95th percentile, but below the 99th percentile, and you can add 5 millimeters of mercury to this, which is, adds a little level of confusion to it. And that's why I think electronic resources are so helpful. You should recheck the blood pressure relatively soon. And if it remains at this level, you can begin some evaluation, which we'll discuss in a moment. Generally, what I have done is, this is not usually a single reading. In the course of either weight management or in primary care, what I would recommend is that if the nurse or MA has taken a blood pressure, it falls into this category, that you repeat the blood pressure immediately thereafter. If it's normal, I would still have the child return in 1 to 2 weeks for a recheck of their blood pressure, or even if it's normal, have them have their blood pressure checked at a pharmacy or somewhere else within a week or two as well. So, so it may just be white coat hypertension, but it may not be. So, but I think it's reasonable to be that careful. If they're at the stage 2 level, really these are high blood pressures that are very high, and if you've repeated it a couple times and it's still high, you can recheck it again. It may be an aberrant reading, but most likely this represents true hypertension that requires evaluation and treatment in a prompt fashion. So this is the NHLBI's rather complex chart, at least I think, algorithm that they've recommended in terms of follow-up. So I don't want to get into too many details here, but essentially if they're normotensive, you can assess other cardiovascular risk factors, give them dietary advice, and then you will reevaluate them. And basically as you move from normotensive to stage 2 hypertension, the degree of evaluation and treatment becomes much more intense. So again, with prehypertension, you assess cardiovascular risk factors. We'll talk about the child 1 recommendations in a moment. You monitor them carefully, and if they persist, you can consider some evaluation. The more interesting aspects are if they are stage 1 hypertension, you can do some basic workup, which would include, of course, family history, sleep history, physical exams, CBC, BUN, creatinine, urinalysis. Renal and cardiac ultrasound is useful, especially for younger children, because they are much more likely to have a secondary cause of high blood pressure, especially renal artery stenosis, and assessment of additional cardiovascular risk factors if needed, lipids and glucose. And of course, you start with weight management. And we will go through a couple of case studies that will illustrate this algorithm a bit better. Stage 2 hypertension, the essential recommendation is that you do the basic workup, and you can do an extended workup through referral. But essentially, most of the time, you're going to begin treatment relatively soon after the evaluation is complete. So the target or the goal for blood pressure is to bring the child below the 95th percentile, and this is ideally for both the systolic and diastolic values. But of course, it is more stringent if they have chronic kidney. And nothing here is extraordinarily unique or new. In fact, nothing in the integrated guidelines is new. It's just a matter of reviewing previous recommendations and trying to decide if those are applicable to children as of just last year. So basically, breastfeeding should be recommended for the first year. Avoiding sweet drinks, of course, which is something I'm very passionate about. In terms of macronutrient intake, fat content of 25 to 30%, no more than 8 to 10% saturated fat, and avoiding trans fats and maintaining a low level of cholesterol. This has, of course, been around for some time. Quite difficult to implement within the context of primary care, within the context of a quality improvement intervention. So I'm going to give you some additional recommendations as well. In terms of activity recommendations, these are the same as the AMA's expert panel, the AAP, etc. Vigorous physical activity for 1 hour a day, limiting screen and other sedentary time as well. Interestingly enough, I was on the AMA's expert panel, and when it came down to a vote, we were trying to vote as to whether or not we wanted to recommend 30 minutes of physical activity a day, 1 hour a day, or 30 to 60 minutes. So I actually voted for 30 minutes because so many overweight and obese children, including those with elevated or high blood pressure, are so physically inactive that to give them a recommendation of 1 hour vigorous physical activity, they seemed a little bit daunting, and I thought might actually discourage people from pursuing any physical activity. So that was my fear. However, others pointed out that 1 hour is the amount that has been shown to actually have some impact upon cardiovascular risk, which is a completely legitimate argument as well. So limiting screen and other sedentary time, of course, is recommended. So the big five in childhood obesity, which I think we've distributed some handouts for, was something that I conceived. It's actually been about 5 or 6 years, and at that time, these were the behaviors for which there was the strongest evidence of their link to childhood obesity. And they're actually very specific behaviors. So online and through ICAP and through the Illinois Public Health Institute, you'll find a lot of brochures, handouts, questionnaires related to the big five. So this here represents the frequency of fast food consumption. So it doesn't really matter what the composition of fast food is. We know that the act of a child entering a fast food restaurant is associated with overweight, obesity, and of course cardiovascular risk, including hypertension. So the recommendation is no more than once a week, according to the American Obesity Association. And that's an extremely important point. Fast food's definition has to be quite carefully done. It's generally speaking, it's food that is prepared, served, and eaten very quickly, usually costs less than $10 per person per meal, and is available in similar forms through either franchise outlets or even through, at home you can have things that are fast food as well. And so that's a definition that's useful because some people don't consider some forms of food to be fast food. So certainly pizza would count as fast food. As an anecdote, I remember at the Weight Management Center in Pittsburgh asking a lady if she and her family had fast food, and she said, no, we don't. We just go to Wendy's. So it gives you an idea that we really need to be careful about how we define it. It's the total volume of sweet drinks consumed per day. Some of you may have heard me say you cannot ask a child, do you drink a lot of pop, nor can you go through the entire list of 9 categories of sweet or high-calorie beverages. So it's better to ask a child, do you drink anything besides water, or did you have anything besides water to drink yesterday or today, which will give you an idea of their usual beverage intake. My preference, of course, is to eliminate all sweet drinks from the diet. It's how often a child has dinner with at least one parent. 5 to 7 days a week is recommended. Sitting in front of the television doesn't count. This is considered to be protective against obesity through several mechanisms. One is that if you are sitting down and eating together, you're probably going to prepare something that's healthier. There are some controls placed upon the types of foods that are eaten, and sometimes the discussion can actually slow things down that takes place around the dinner table as well. So there's lots of benefits from sitting and eating together. The total amount of screen time a child is involved in per day. Screen time encompasses television, video games, computer time, apart from schoolwork, tablet computers, of course, music players if the child is sitting still. So anything that counts for screen time is extremely important. And it's the total number of days in which habitual physical activity is carried out for whatever your preference is, 30 to 60 minutes or 60 minutes a day. It does not necessarily have to be gym class, doesn't necessarily have to be a sport, but it should be sustained for that time per day in a cumulative fashion. So here's a sample Big Five questionnaire that you can use. Do you eat regular fast food? Do you consume more than one serving of sweet beverage? Do you participate in a minimum of 30 minutes of physical activity per day? Do you eat dinner with at least one parent or at least one adult most days of the week? And do you watch television, play video games, use a computer for more than 2 hours a day? So these aren't my specific recommendations. These are from the AAP and from other organizations. They've just been compiled into a set of questions that I think is a little bit more practical than some of the Child 1 recommendations that are in the NHLBI combined guidelines. So the next step, of course, once we have instituted some lifestyle changes, is to consider pharmacotherapy. This is an area in which a lot of people are still somewhat uncomfortable, but it's important to keep in mind that a number of medications are FDA approved for use in children. These include the angiotensin-converting enzyme inhibitors, the ARBs, beta blockers, calcium channels, and diuretics. So essentially the things that are approved in adults. And a lot of these have been studied for a number of years. And we'll talk about what to how to progress a child or how to consider treatment through a couple of case scenarios in a moment. And whom to consider as well. So here is the very, very basic case study. So Marlene is a 14-year-old girl who comes to see you accompanied by her mother for a routine well child visit. She's generally been well, has no significant past medical history, has not had a checkup in several years, which is kind of a typical adolescent situation. So she's 170 centimeters tall, so that's quite tall, about 5'7", 5'8", and she weighs 85 kilograms. And you've taken her blood pressure twice, and the average of those two readings is 145 over 80. Her BMI is 29.3. The BMI percentile is about the 96th percentile. So she is very slightly above that obese target of 95th percentile. The blood pressure percentile, however, based on her systolic pressure, so whichever of the systolic or diastolic put them in the higher category is how the blood pressure status is determined, is in the stage 2 range. So she has stage 2 hypertension according to this. You do a basic workup, and that can be the family history, maybe checking additional cardiovascular risk factors, including lipids, for example, and you do renal function testing, CBC, urinalysis, and that's essentially a basic workup. There's nothing remarkable about it. She returns back in 1 week, and she's at 135 over 70, which is a little bit better in stage 1 range, let's say. We make some diet and activity recommendations, and we monitor her for about 3 months. Now, this is not an atypical situation. She returns about 3 months later. She was at 85 kilograms, but has now put on quite a bit of weight. She now weighs 93 kilograms. Blood pressure is back to up to 150 over 90, back in the stage 2 range. So at this point, we can consider starting her on medication. Let's say we start her on amlodipine, 5 milligrams once daily. This is a relatively modest dose of a well-studied calcium channel blocker. We, of course, continue to encourage lifestyle changes, and we continue to monitor her over 4 to 6 weeks. The blood pressure, as she follows up, is 140 over 80. She's lost not much weight, really, which, of course, is a fairly common situation. She's gone from about 93 to about 91 kilograms. We increase the amlodipine to about 10 milligrams daily. Careful monitoring, not just of blood pressure, of course, but of course of side effects as well. She's starting to do a little bit better in terms of her weight. After an additional 6 weeks, it's about 88 kilograms. Her weight has come down significantly. She's still not back down to the 85 that she was. The blood pressure is now 122 over 70. So we continue with encouragement and monitoring of lifestyle changes. So 122 over 70 is within the target that we want. We want her to be below the 95th percentile in terms of treatment. The question that often comes up, and let's say this whole process with this particular case has taken approximately 4 or 5 months or so, is do we continue the amlodipine indefinitely? And that's a question that comes up a lot from parents as well. So in the weight management center that I ran for a number of years, one of the promises that I often made to parents is if the child loses a significant amount of weight, and we're assuming that there's no obvious secondary cause of hypertension, and in most cases there isn't, and their blood pressure is well controlled, we can start to taper off the blood pressure medicine and hopefully eventually get them off medication entirely. So in this case, in the case of Marlene, if she continues to lose weight, let's say she gets to, she is slightly obese to, let's say, the overweight range, so she goes from about 88 kilograms to perhaps about 78 kilograms or so, and her blood pressure remains well controlled on 10 milligrams of amlodipine, I would certainly consider decreasing it to 5, see how she responds, and perhaps being able to discontinue it entirely, which I think will provide some encouragement for her to achieve a healthier lifestyle. So here are some basic summary recommendations based not only on the case but on some of the material that we've covered. So make sure your office is following guidelines for measurement of BP. So these should be fairly standard. So you have older adolescents, 18, 19-year-olds coming in, make sure they get their blood pressure checked every single time. The complex standards make interpretation of blood pressure screening results very challenging. I really believe strongly that you don't have any real option except for using an electronic system. And so, you know, because I can say this pretty confidently based on my experience with the charts and trying to implement charts in primary care practices. So the electronic system does not necessarily have to be an electronic health record system. You can use a freestanding program. The one I showed you is just one example. It's inexpensive and widely available, but there are others as well. In the context of busy pediatrics practices, screening, counseling, and follow-up should be made as automatic as possible. So this was a proposal that we started at North Shore. So essentially the process is that child's blood pressure is taken, the blood pressure percentile is automatically recorded, so the screening is taken automatically. The counseling can take place either during the physician encounter or even as part of an after-visit summary, and follow-up recommendations should also be made. If this is too automated, of course, if it's all just automatic and the physician is not involved, the patient will come back with questions, etc. So physicians do need to be involved. But they cannot be burdened with trying to track down every single elevated blood pressure, for example, or making sure that every child follows up at the correct interval. Monitor children with elevated readings frequently. So I have traditionally monitored them even more often than what's recommended. So if a kid comes in with stage 1 hypertension, yeah, it's true you can see them again in a week or two, which is what's recommended. But you know, given the how widely available blood pressure machines are, etc., I think you can and certainly have their blood pressure taken much more often than that to make sure that it's elevated and to characterize the degree of elevation. Once you've done a basic workup, which makes essential hypertension the most likely diagnosis, recommend lifestyle changes. So the basic workup that's recommended in the cardiovascular risk guidelines is that detailed family history, the repeat blood pressures, a CBC, a renal function testing, and perhaps a urinalysis. Now, the question comes up, when should you suspect secondary hypertension? Well, that's a difficult question. So we know that around age 11 or so, essential hypertension begins to become the predominant form. And when they say essential, this is related basically to overweight and obesity, and doesn't have any obvious underlying cause or not so obvious underlying cause, such as coarctation of the aorta or renal artery stenosis or pheochromocytoma, all of which are relatively rare. Renal artery stenosis is by far the most common secondary disease entity. There, of course, can have hypertension that's secondary to medications, etc. So you can do a basic workup and establish essential hypertension based on the basic workup. If the blood pressure is extremely high, if the child is pretty young, let's say well below 11 years of age, then you do have to look further. So you can think about an ultrasound of the kidneys or referral for more specialized testing. But basically, once you've completed a basic workup, the next step is to progress with lifestyle changes. And these you may have some mixed success with, but I think that because we are starting on this journey of trying to manage blood pressure better, and it's not just unfamiliar to physicians and to the healthcare community, but also to parents and to families as well. So immediately, jumping to medication is something that doesn't get a very warm reception from a lot of parents, as you can imagine. Now, if lifestyle changes are unsuccessful, let's say over the course of 6 months, you haven't had much success in modifying the child's diet according to the child criteria, or they're still as heavy as they were, or if they're in the stage 2 range, begin pharmacotherapy with a simple single drug regimen. The example that I gave you with the case of Marlene is to begin with amlodipine, but you can begin with any of those medications. The typical pattern is to become familiar with 1 or 2 agents and to go up on dose as needed. And if you need to add a second agent from a different class, that's certainly something that can be done as well. At that point, of course, you may also want to consider referral to someone who specializes in treatment of hypertension. But the vast majority of cases can be handled by us in the primary care setting. So I am going to stop here. We have about, I think, 12 minutes left or so for any questions. and turn things over to Sarah at this point.
Great. Thank you, Dr. Rao, very much. At this point in time, as he mentioned, we do have a few minutes left for questions. So if anybody has any questions at this point, I would encourage you to either type them into the question panel at the bottom of that screen on the side, or you can go ahead and raise your hand, and I can unmute you and you can ask the question that way. So it says here, okay, Dr. Weiss has a question. So Dr. Weiss, I'm going to unmute you and you can ask your question.
Do you have any specific recommendations as to whether to start with an ARB versus an ACE inhibitor versus a calcium channel blocker? I mean, previously I saw a lot of use of diuretics, but I'm seeing less of that now.
Okay, so thanks very much, Dr. Weiss. So that's an excellent question. And that's exactly the pattern that has come out. So there are some anecdotal reports that we probably should not be starting with diuretics quite as often as we have been due to potential side effects. So in terms of what I recommend, I definitely recommend starting with a calcium channel blocker or an ACE inhibitor, mainly because that's what I'm most experienced with, and you don't run into a lot of cost and insurance issues. So, over the course of 9 years or so that I was running the Pediatric Obesity Center, we had several hundred kids who were being treated for high blood pressure, and I always generally started with low-dose ACE inhibitor or low-dose calcium channel blocker, and had very good success in controlling blood pressure.
Great. Any additional questions? Okay. So it looks like we don't have any more questions at this time. As you're going through your charts or thinking about making changes in your practice and you come across a question, please feel free to email myself or Billy, and we will be happy to pass those questions along to the experts and get those answered. A couple of points of business. The NHLBI pocket guide that Dr. Rao referenced in his presentation will be put on the LMS in the tools section, so you will be able to find it there, to download it, to use it as you see fit. Additionally, I'd just like to remind you about the QI calls. This month we have one this Friday from 3 to 4, from Monday the 18th from 3 to 4, and on Wednesday the 20th from noon to 1. If you haven't signed up for one, please go ahead and be sure to do that. They are very useful opportunities for you to talk with other participants and Dr. Rao about how things are going in your practice.